Hey there, I'm Professor McBride, labor nurse, OB instructor, and your guide to everything OB. Let's get to it. So now we're going to take some of this information that we just discussed and we're going to apply it to a patient. So we're going to talk about Abby. Abby is 17 years old and she comes into the prenatal clinic. What kind of symptoms could Abby be experiencing that would cause her to think she could be pregnant? So what kind of signs would these be? Think about these are things she's experiencing. So these would be presumptive signs. So what kind of things might she be experiencing? Maybe she missed her period. Maybe she's peeing a lot. Maybe she has breast tenderness. These are all subjective things. So amenorrhea, breast changes, nausea and vomiting, urinary frequency, fatigue, these would all be what type of signs of pregnancy. These are presumptive signs. So she comes into the clinic with these signs and she says, I have never been pregnant before. If Abby is pregnant today, would she be considered a nulla gravida, a primigravida, or a multigravida? So remember that if she is pregnant today, this would be her first pregnancy. She says she's never been pregnant before. So she wouldn't be a nulla gravida if she's pregnant today because nulla is 0. And she wouldn't be a multigravida because a multigravida has had multiple pregnancies. And she says this is her first pregnancy. So she would be a primigravida. Prima is 1, the first pregnancy. Would she be considered a nullipara, a primipara, or a multipara? So remember that for this, we're talking about parity. These are number of completed pregnancies after 20 weeks of gestation or number of deliveries. If this is her first pregnancy, has she had a delivery before? She has not. So she would be a nullipara. She will not have had a delivery before. If she's pregnant today, what would be her GTPAL? So gravida would be 1. It's the first pregnancy. Has she had any deliveries? She has not. So term deliveries is 0. Preterm deliveries is 0. Abortions are 0. And living is 0. So her GTPAL is G1, T0, P0, A0, L0. And we can also see it potentially written, remember, with just the numbers. Then you see G1 is gravida 1, para 0, 0, 0, 0. So let's determine Abby's due date. So we're going to use Naegele's rule to determine the due date. And so Abby says her last menstrual period started on August 25th, 2025. Using Naegele's rule, what would be her estimated due date or her estimated date of delivery? So to do this, we're going to take the first day of her last menstrual period, and we're going to subtract 3 months, and then we're going to add 7 days, and then we're going to add a year. And we're going to come up with the due date of June 1st of 2026. The most reliable way to determine the gestational age and due date is going to be by ultrasound. And the first trimester ultrasound is going to be the most reliable. It actually measures the crown rump length from the top of the baby's head to the rump or their bottom in centimeters. And we usually do this at around 7 to 13 weeks gestation. So let's look at how we break down Naegele's rule. All right, so we're going to take the first day of the last menstrual period, which she said was August 25th, 2025. And then we're going to subtract 3 months. So we're going to move back 3 months from August to May. Okay. And then we're going to add 7 days. So we move forward 7 days from the 25th to the 1st. And that puts us into the next month. So now we are at June 1st. And then we need to add a year. And so we go from August 25th, 2025, then subtract the 3 months becomes May. Add the 7 days gets us to June 1st, add the year gets us to June 1st, 2026, and that would be her estimated due date, is June 1st, 2026. So Abby's pregnancy test is positive. So what sign of pregnancy is that? Remember that a positive pregnancy test is something that the practitioner or the nurse can assess, and so it's a probable sign of pregnancy. And then her ultrasound showed an intrauterine pregnancy with the due date consistent with her last menstrual period when we used Naegele's rule. So what sign of pregnancy is that if we did the ultrasound? That's a positive sign. And our due date is the same as what we estimated with Naegele's rule. So for her testing for her first prenatal appointment, we want to start looking at, we're going to check her weight. We're going to check her vital signs. We're going to check her urine. We can test for STIs. We're going to check blood work. We're going to look at her blood type. And then depending on where she's at in her gestation, we might also check her alpha-fetoprotein. So for weight, it's important to determine what her weight is and to watch for weight gain during her pregnancy. So we start that from the beginning. Vital signs, we want to know the baseline vital signs. We're also watching those consistently and watching for signs of hypertension and things like that throughout the pregnancy. For the urine, we can look for signs of a UTI, but we're also really watching that urine for protein as the pregnancy progresses. STIs, if she's positive for any sexually transmitted infections, they will consider treating these. If it's things like gonorrhea, chlamydia, stuff like that, we need to treat them. If she is positive, like for HIV, she would need to be on an antiretroviral through her pregnancy. So different infections can cause different types of treatment that will be important during pregnancy. We're going to check her blood work, and we want to know the CBC. We want to know what her platelets are starting out. We want to know H&H to know if she's anemic. We also want to check and see if she's rubella immune or non-immune. And then we also need to know her blood type. Blood type is very important with pregnancy. If the RH is negative, we need to address that, which we'll talk about some more in a minute. And then the alpha-fetoprotein is something that we check. If it's low, that can be a sign of Down syndrome, and if it's high, that can be a sign of neural tube defects. So for Abby at her next prenatal visit, her blood pressure is 110/70. She has lost 4 pounds. Her urine is normal. Her fetal heart by Doppler is 140, which is good. Her blood type was B negative. Her hemoglobin was 9.8, and her alpha-fetoprotein was elevated, and her rubella is non-immune. So thinking about the type of things that we need to address for Abby, when we think about her weight, she's lost 4 pounds, and so that is not normal. Typically, in pregnancy, a woman with a normal BMI to start will gain about 4 pounds in the first trimester, and then a half a pound to a pound a week after that, for a total weight gain of about 25 to 35 pounds. So the fact that she's losing weight is concerning. So we need to think about why she's losing weight. Maybe she's having a lot of nausea and vomiting in pregnancy. Maybe she has hyperemesis. Maybe she has pica. Pica is when they crave non-food items, and that's what they're eating. So they're eating dirt, chalk, clay, freezer frost, stuff like that. And so they're not getting the nutrients and calories that they need. So there's a lot of different things that it could be. So we need to teach Abby what the normal expected weight gain is. We need to do a nutrition assessment and find out what she's eating. We need to figure out what her dietary preferences are so we can help her choose foods that fit with what she will eat, that will help her grow her baby. And then we also can assess for pica as well. Abby, being a teenager, she would probably benefit from a dietary consult. Teenagers have a higher risk in pregnancy of having babies that are small for gestational age or intrauterine growth restriction. And teenagers also have a higher risk of developing anemia, and that's another thing we'll address because her hemoglobin is low. So that's another thing we could consider as well. What should the nurse plan to administer at 28 weeks based on her blood type? So we're looking at her blood type, and her blood type is B negative. So what should we plan to administer at 28 weeks? We should administer rhoGAM, okay, because her RH is negative. What education should we provide about her anemia? So her hemoglobin is 9.8. So it is normal for women in pregnancy to have a lower hemoglobin amount, and it's called physiologic anemia. And this happens because when the woman's blood volume increases, the volume increase is more plasma than red blood cells, and so it dilutes the red blood cells. Okay, so the red blood cells production goes up, but the plasma goes up more. And so it's not unusual to see hemoglobin as low as 11 in pregnancy, but below that, we're concerned that this is more of an iron deficiency. And so the fact that she's 9.8, she definitely needs to have iron supplementation. And that also could lean back to when we were talking about if she was experiencing pica because of her weight gain. We were thinking about things that could be contributing to her not gaining weight well. If she's having pica, pica often is caused by iron deficiency. So she has an iron deficiency anemia already, we can see, because her hemoglobin is 9.8. So when we think about what she needs to know related to her anemia, she needs to take iron. And so we want her to know that she will be taking it for at least 3 months because that's how long it takes to build up new red blood cells. She should not take iron with dairy products, with tea, or with coffee, but she should take it with citrus fruits and juices because that can help with absorption. Iron can also cause constipation and GI upset. Her alpha-fetoprotein is elevated, and so that could be a sign of neurotube defect. So when we think about what could decrease the risk of neurotube defects, we would have wanted her to take folic acid before she even got pregnant if she was planning to become pregnant to decrease that risk of a neurotube defect. Now that we know her alpha-fetoprotein is elevated, then we need to potentially evaluate the possibility of a neurotube defect for her baby. And so we can start this with an ultrasound and see if we see any signs of neurotube defect on ultrasound. The other thing that can be done here is an amniocentesis. An amniocentesis is going to be where we actually go in and take out some amniotic fluid. So this is invasive. And they use an ultrasound to watch where the needle is going in, and they take a little bit of amniotic fluid out with a needle, and then they can look at that and tell definitively if the baby has a neurotube defect. This is going to be a decision to make if we're concerned based on the ultrasound. It has risks associated with it, a risk of infection, risk of causing miscarriage, things like that. So it's a decision if they want to choose to make. And then the fact that her rubella is non-immune, she needs to be vaccinated. Rubella is actually very dangerous for a fetus, but the vaccine is a live virus, so we cannot give it to her during the pregnancy. So this will be something that she should get right after delivery when she's postpartum before she discharges. Okay. So other things to consider for pregnancy care and testing. What additional testing done routinely throughout pregnancy will Abby be educated about? So ultrasound, we do an ultrasound typically in the first trimester to determine the due date and gestational age. And then we might do an ultrasound again. We typically do an ultrasound around 20 weeks that looks at all the organ systems and looks at the status of the baby. We might do ultrasound at the end to determine if the baby's head is down. We might do ultrasounds if we need to look at how much amniotic fluid she has and things like that if she has like a high risk pregnancy. But ultimately, the main times that they get an ultrasound, the main time is at the 20 week. The other ones are possibilities. She doesn't get an ultrasound at every appointment. We test any woman who is not diabetic will get what's called a glucose tolerance test. This is a test that's done at about 24 to 28 weeks, and this is to look for gestational diabetes. So if a woman has diabetes, she already has diabetes. We're not going to test her for diabetes. But some women then can develop what's called gestational diabetes, and this is something we would test for. Group B strep. So group B strep is something that can live in the normal flora of women, and it can come and go. It's not something that is concerning just normally, but it is dangerous for a baby. And so it has a high neonatal mortality rate if the baby contracts it. So we test all women at about 35 to 37 weeks for group B strep. If they're positive, then we're going to give antibiotics during labor. And if they're negative, then we, at that time, at the 35 to 37 week mark, we anticipate they will remain negative for those last few weeks of pregnancy. So if it's positive, then we just know that she's going to get antibiotics. So every visit, so those are not every appointment, those are certain times that we do those three. Every visit, we have a few things that we will be doing. Okay, so we're going to check the vital signs. We're watching the blood pressure. We're looking for if she develops hypertension. We're watching her weight gain to make sure that it's normal. We're going to check fetal status. So once we're able to hear the heartbeat via Doppler, we'll listen to the baby's heartbeat each time. And then at 20 weeks and beyond, we're going to start checking fundal height. And the way we check fundal height is we measure from the symphysis pubis, or the pubic bone, up to the top of the fundus, where the uterus is. And this measurement in centimeters should be the same, roughly, as the gestational weeks. And we say plus or minus 2. So if she's 24 weeks, what should her measurement be? Between 22 centimeters and 26 centimeters. If it is more or less than that range, that can be a sign of fetal growth restriction. That can be a sign of macrosomia. It can be a sign of polyhydramnios, depending on where we're at. So if we have an abnormal fundal height measurement, we know that we need to investigate further, and we need to look to see why. So this can give us a rough estimate of fetal growth, so that we kind of know where our baby's at and if it's growing as anticipated. Okay, we're going to check the urine at every appointment. This is looking for protein, and then intimate partner violence screening is always important at every appointment as well. It is possible for there to be more tension during pregnancy, and some women are subject to intimate partner violence during pregnancy that hadn't had that happen before. So it's something we should be screening for every time. Things to educate about: normal discomforts versus potential problems. So normal discomforts in pregnancy there's a lot of things that are happening in the body during pregnancy. So breast changes, so her breasts will enlarge. The areolas will become darker. So we're seeing pigment changes. We're seeing maybe stretch marks on her breasts and on her belly. That's all normal. Urinary frequency is normal. Fatigue is normal. Nausea and vomiting, if it's not like hyperemesis where she's vomiting all the time. Some nausea and vomiting in pregnancy is normal. Pigment darkening, so we're thinking about not only that the areolas on the breast can darken, but also linea nigra, so the line on the abdomen from the belly button down, that is finding. Melasma or chlasma, which is a darkening of pigment on the face, that's normal. Heart palpitations. So since the blood volume increases so much during pregnancy, some women have palpitations during pregnancy. That can be a normal finding as well. Faintness can be normal. Heartburn can be normal. Constipation. Round ligament pain. Round ligament pain has to do with the ligaments that hold the uterus in place, and as the uterus is expanding and growing, these ligaments get stretched and pulled, and so they can have pain in the right or left lower quadrant from that. Leg cramping is normal. and supine hypotension. So supine hypotension is going to have to do with, if you look at this picture and you think about the fact that if the main vessels from the heart are running behind the uterus, supine is her laying on her back. If she lays on her back and the weight of that baby in uterus are putting pressure on those vessels, it's going to affect her blood pressure. It affects her blood pressure. It makes her feel bad. It also then affects perfusion to the placenta, because remember that the placenta depends on blood pressure. So if her blood pressure goes down, that affects perfusion, and so that affects the baby as well. So this is why we encourage women not to spend time laying on their backs. They should lay on their side. But if we're measuring her fundal height, we put her on her back, things like that. So we won't have her spending much time on her back at all. So this is supine hypotension, and this is why, even though it's something that happens that's normal, we don't want to encourage it to happen. So we want her not laying on her back. As far as potential problems go, things that she should report: bleeding, okay? At the very end of pregnancy, it's not unusual if she's starting to labor to have some bloody show. But prior to that, we shouldn't be seeing bleeding. Leaking of fluid before 37 weeks. That could be a sign that her water broke early. Decrease or absence of fetal movement. Once she starts feeling fetal movement, she should continue to feel fetal movement. And we're going to actually teach her how to track that, which we'll talk about. Heartburn if it's accompanied by headache. So even though heartburn in pregnancy can be a normal finding, epigastric pain can present like heartburn. So if we have epigastric pain or heartburn and we have a headache, those two combined could be signs of preeclampsia. So we would want to know if she's experiencing that. If she's experiencing epigastric pain, also that can be a sign of preeclampsia. Flank pain could be a sign of UTI or kidney infection, so we would want to know about that. Severe headache unrelieved by Tylenol could be a sign of preeclampsia. Persistent severe vomiting could be a sign of hyperemesis. Burning on urination, so urinary frequency is normal, but burning is not, so that could be a sign of a UTI. Visual disturbances, blurring, spots in her vision, also concerning for preeclampsia. Contractions or pelvic pressure prior to 37 weeks could be signs of preterm labor. And then those unusual cravings could be signs of pica. So any of these symptoms she should report. So any of the things that are happening on the left column are things that we can reassure are probably normal findings. Anything on the right column are things she should tell us about. So when we think about additional testings and assessments, there's other things that we would consider, and we already talked a little bit about the amniocentesis. So there's a few other things here to think about. The non-stress test and the contraction stress test, these have to do with fetal monitoring, and we're going to talk about that a little bit more in a minute, as well as the biophysical profile. The biophysical profile is a test that we can do that is going to give us a much better look at our fetal status, and so we're going to talk more about that on the next slide. Fetal kick counts we'll talk more about on the next slide. This is going to be where we teach her how to determine how often her baby's moving as a sign of fetal well-being as well. rhoGAM is going to be something we give if we need to, based on if her RH is negative. But the other thing I want to talk about on this slide is the Leopolds maneuver. So the Leopolds maneuver is a way of determining the position of the baby. And so we'll do this sometimes at the end of the pregnancy, also on labor and delivery. If we're determining, we want to make sure the baby's head down, we're determining where to put our monitors. And the way we do Leopolds is to palpate. So we feel the top of the uterus first, and then we come down the sides. And when we're on the top, we're feeling for that solid mass. So it's either a head or a butt, unless the baby's transverse. And then we come down the sides, and one side should be smooth because it's the baby's back, and one side's more lumpy, bumpy, and that's the small parts, the arms and the legs. And then we feel right above the pubic bone, and this is going to help us know if that's a head. If you put pressure and you kind of wiggle your fingers, the head will bobble between your fingers. And so this is Leopold's maneuvers to determine fetal position. If you're using Leopolds to determine where to put a fetal monitor, you're going to put it where, if the baby's head down, you're going to put it in the lower quadrants, and you're going to put it where the baby's back is. So on that smooth side. So let's look at some of these other things a little more closely. The way that we are going to do it is based on something happening with Abby. So Abby is now 34 weeks, and she realizes that she hasn't really been feeling her baby move today. She's been monitoring her fetal movement by something she was taught at her prenatal appointment. So what might she have been doing to monitor her fetal movement? Daily kick counts. So the way we teach mamas to do daily kick counts is we want them to pick a time during the day that their baby is usually most active. Babies tend to be on a schedule. And so whenever we're at a time that the baby is most active, then that's going to be a good time to pick. And we just, during that time of day, each day, we want her to just notice that her baby's moving. And we would like to see 10 movements in 2 hours. Once she's felt 10 movements, then she knows that all is well. If she notices, though, that the baby's not moving as much, then she needs to pay more attention. So she's going to count at the same time each day. The goal is 10 movements in 1 to 2 hours. So she tried to do her kick counts, and she only felt 1 kick in that first hour. So she laid down on her side to assess longer and didn't feel any further fetal movement. So she calls her doctor. So what do you think that she'll be instructed to do? She should come in, and we can monitor her baby. Okay. So she comes to the clinic, and she's put on the monitor for a non-stress test. So I said we were going to talk about the non-stress test. So the non-stress test is when we put a monitor on that listens to the heart, and then we put another monitor on that looks for contractions. And really, with a non-stress test, that means we're not creating stress. We're not trying to make her have contractions. If her body is contracting on its own, that's fine, but we're not giving her like Pitocin and making her have contractions. So we're just going to look at the tracing. And with a non-stress test, we want to look at least 20 minutes of the tracing. And during this time, we would like to see a few things that would be reassuring to us. Okay, reassuring is going to be signs that the baby's doing well. Non-reassuring findings are going to be signs that don't reassure us. So are either concerning or don't give us enough information. So Abby's fetal heart tracing has minimal variability and no acceleration. So this is not reassuring, okay, because this is not giving us an accurate picture of things that would give us an idea that our baby is doing well. So what assessment findings would be considered reassuring? We want a normal baseline. So that means that the place that the heart rate is hanging out the most is in that normal range. And the normal range for a fetus is between 110 and 160. Okay. We also would like to see what's called moderate variability. And so we talk more about all of these things with fetal heart tracings on a different recording, and I will link it to this. But variability is the variations in the heart that happen, and it's just the give and take of the sympathetic and the parasympathetic nervous system. This is supposed to be between 5 and 25 beats of variation. And a baby that's well oxygenated has that. A baby that does not have that, it does not necessarily mean that the baby is not well oxygenated. If we have minimal variability, our variations are less than 5 beats of variation, and that could be a sign of hypoxia for our baby. But it also could be a sign that the baby's taken a nap, or it also could be a sign that the baby is sedated because we gave mom fentanyl or something like that. So minimal variability in and of itself isn't definitely concerning, but it's also not reassuring. So for Abby's baby with minimal variability, that's not very helpful. Okay. If we had moderate variability, that's that variation between 5 and 25 beats, and I want to see that. If I see moderate variability, I do know that that baby's well oxygenated. Okay. So then the other thing that we're going to look at is accelerations and decelerations. Accelerations are increases from the baseline, and they need to increase more than 15 beats above the baseline and last for at least 15 seconds. And accelerations are always reassuring. Abby's baby doesn't have any accelerations on the tracing right now. An absence of accelerations doesn't necessarily mean anything's wrong. It just doesn't, it's not a reassuring finding. Okay. And then the other thing we're going to look at is if there's decelerations or decreases. And the decreases are going to give us an idea of how the baby's doing as well. So what we would want for a reassuring tracing is we would want a baseline between 110 and 160 beats per minute, moderate variability where the squiggly line is between 5 and 25 beats of variation, and we would like to see at least 2 accelerations in that 20-minute tracing so that it goes up by at least 15 beats, it can be more, and last at least 15 seconds. And then we shouldn't see any decelerations in the heart rate. These are going to be the things that are considered reassuring for the non-stress test. Abby's baby doesn't have that. So the next thing we might consider is what we would call a biophysical profile. With a biophysical profile, we're going to use the tracing as one component of the biophysical profile, but for the other components, we're going to do an ultrasound. And with an ultrasound, we're going to look at breathing movement. So remember that the baby, even though the baby is in utero and isn't breathing oxygen, they still make breathing movements because they get the amniotic fluid in the alveoli. So the diaphragm still moves, okay? We're going to look for breathing movements. We're going to look at the AFI, which is the amniotic fluid index, or how much amniotic fluid is in there. We're going to look at the baby's muscle tone and if the baby's moving. And then the non-stress test is the other component. Each of these get a score, and the higher the score, the better that the baby is doing, the more reassured we are that the baby's okay. If the score is low on a biophysical profile, that's very concerning that there could be fetal compromise. And oftentimes with a low score, we will move towards delivery. And then that's it. So that is the main things that we're watching for, testing for, assessing how to do the main parts of our prenatal care and pregnancy considerations. Thanks for watching. Be sure to subscribe, like, and share for new videos every week about everything OB. See you soon.